Assalamu alaikum. Today's lecture is about intra-aortic balloon counter-pulsation. I need to put algorithmic approach for the troubleshooting. I will have a case, describe the case, and see how can we approach the patient.
Intra-aortic balloon pump counter-pulsation. Its name, intra-aortic, means inside the aorta. Its level, which would be 2 centimeter less than left subclavian and above the left renal artery. This is the position. And the pump, it's balloon inflated and deflated. The balloon is inflated in diastole, deflated in systole. And pumps acting like when it's inflated, it take about 80 to 85% of the aortic size. So it acting like a pump, pushing the blood outside the aorta. Counter-pulsation, it's like the balloon giving pulsatile flow, but the pulsatile flow is different from the aorta. The aorta different from the heart itself. The heart contracting in systole, but the balloon is deflated in systole. The heart is relaxed in diastole, but the balloon is inflated in the diastole. That's mean by counter-pulsation. So the primary effect of the balloon is decreasing oxygen demand and increase oxygen supply. And the demand will increase by deflation, which decrease afterload. And this afterload is decreased by decrease aortic and the diastolic pressure. And all of that will reflect to increase stroke volume and so the cardiac output. And the supply will increase by inflation of oxygen, will increase by inflation, which will lead to displacement of the blood into the periphery and coronary arteries, so increase coronary artery supply and increase systemic perfusion. After quick revision of intra-aortic balloon pump physiology, I will have live case, which is 72 male patient. This patient has a medical history of triple vessels disease, coronary artery disease, with chronic heart failure with ejection fraction less than 25%, and type 2 diabetes. The patient went to OR for coronary artery bypass. He does CABG by 3, Lima to LAD, and vein to OM and RCA. Here, I will not show any console or any something to interpret it because I explained before, but I will give here the clinical summary of the case. The patient, after 6 hours post-op, will have clinical, clinical situation. The nurse report there is decrease on augmentation arterial waveform, intra-aortic balloon pump showing timing error. The map dropped from 75 to 60 millimeter mercury. The patient is oliguric and mottled. Vital signs show that heart rate 94 beat per minute sinus rhythm, blood pressure 85/50 with the mean arterial blood pressure 60 millimeter mercury, central venous pressure 10 millimeter mercury. Arterial waveform show poor augmentation and inflation mistimed. So we will go for the assessment and for the patient on intra-aortic balloon pump. First, what's the initial check? We have balloon inflation and deflation, deflated and inflated, but not synchronized with the ECG waveform. Inflation occurring early prior to the dicrotic notch, and deflation is delayed after systole and that increase afterload, but there is no alarm or for helium leak or gas loss. So that's mean timing error is likely due to improper inflation and deflation. There is the reduction in coronary perfusion and increased myocardial oxygen demand.
Intra-aortic balloon troubleshooting should be step by step, from trigger to clinical assessment. So the first two steps is 2T, trigger and time. Confirm trigger source. The current trigger is ECG, which appears stable, it's a sinus rhythm. But we can consider to switch to arterial pressure trigger if we have ECG of poor quality, or we can adjust the ECG leads if we need more clear ECG signals. We assess timing using intra-aortic balloon waveform and ECG guide to inflation occur at the dichrotic notch, deflation just before R wave, the start of systole, manually adjust time setting using time control key on the console. So first trigger, second time. The third part is to assess balloon function. After trigger and assess the timing, so we will assess the balloon function. We should check the console for presence of helium gas pressure and the battery function, inspect the tube for kinking, connection, or presence of leak. Clinical monitoring post-troubleshooting. If we solve the issue, we should monitor the augmentation of blood pressure waveform, the augmented blood pressure waveform. Also monitor the mean arterial blood pressure, urine output, and lactate level. Also, we can check EBG and the mixed venous oxygen saturation if necessary. Part of this troubleshooting, we should check the position of the balloon. It should check the outside in the leg to the other side of the insertion for any bleeding, and on X-ray to see its position, it's high or low or in a proper position. It's slightly high, and its reflection on the uh, console or arterial blood pressure waveform with slightly early inflation, and to differentiate between the early inflation, late inflation, early and late deflation, it's in separate lectures. Here I wanted to go how to be an algorithmic approach for the troubleshooting. This is the same case after fixing the balloon. We draw it down, so proper inflation in the balloon, and it's going at the carotid notch immediately and adjusting the deflation. The patient now had MAB 75, good urine output, and the tachycardia slightly reduced than before. And we now take EBG and see normal lactate and enhancement of the oxygenation, and SVO2, central venous oxygen saturation, is normal, and the patient marvelously improved.
This is a reference for this lecture, which I depended on it for this lecture. Thank you. You can put your comment and questions in the blue comments.